Hello everybody, my name's Emily. I'm a final year paediatric trainee, and as you've heard, I work with Dr. Dahuda, who is my supervisor and has kindly asked me to come along today to discuss some of the work that I did last year as part of a Masters in Global Health Policy, looking at why people leave paediatrics and what we might do to try and encourage people to stay within paediatrics if that's at all possible. Just to start off, this is mainly focusing on doctors, so apologies for all the nurses and other healthcare workers in the room, but I'm sure some of these points also apply to you as well. And also we need to consider that it's not always a negative to leave a specialty, because there's lots of different things that people can do in different walks of life having experience in paediatrics. So first of all, we know there's a global health crisis in health workers all over the world. There aren't any health workers, or not enough health workers. And in order to get the right people in the right place at the right time, what we need to consider is that there's actually a market, so a labour workforce market. And that is looking at the interaction between demand and supply of health workers. And actually what's needed for that is to consider ultimately human behaviour and human motivation. So we know the NHS is in a big bother, and it employs about 13% of the total population. But actually, we know that there's crises in lots of different of the specialties. But of course, I'm going to focus on paediatrics, but we know that lots of policy, like the uncertainty around that terrible word Brexit, and immigration policy and policies of austerity all contribute to these things. Also policies related to training itself, such as modernising medical careers, and more recently the shape of training review. And there's also changes in individual preferences. Lots more people are now choosing to work less than full time, and that's creating lots of gaps. And there's a big thing made about generational differences, so the differences between the pre-war generation, who were the generation of sacrifice, and those terrible millennials who want something for nothing, which I hope you can agree is probably a bit of an oversimplification. I think I'm hopefully going to show you that it's a bit more complex than that. So I look at paediatrics. So of course paediatrics is close to my own heart, but we do know that rota gaps have increased across the board, and particularly at middle grade level, particularly in certain specialties such as neonatology and in certain areas of the country. And that's all while demand for services grows. We know that in paediatrics it's the fourth shortest specialty in the UK, however it doesn't attract the new pay premium in the new junior doctor contract, which is quite interesting. When I did the project, I thought, well, everybody must be leaving paediatrics. That's why there's so many gaps, because I could see everybody leaving left, right and centre. That's how it felt at the time. But when I spoke to the Royal College of Paediatrics, they told me that actually most of the gaps in paediatrics are created by increased less than full-time working. And what they suggested was that it was people taking increased parental leave that were causing the gaps. I wasn't sure about this because that's not how it felt, and I know that it's different in different areas, so I felt that there was a need to think about retention as well as increased recruitment. There is a strategy for the Royal College. They aim to increase trainee places, and they aim to change immigration policy and coordinate central planning. Now, they don't actually monitor people that leave paediatrics. We have no idea how many people leave paediatrics, and we have no idea where those people go. So I think that's, again, something that needs to be changed, and I'm sharing my project, and hopefully they will be able to do that. But my project was looking mainly at retention. First of all, I did a big literature review. I looked at all the evidence for why doctors choose careers in different ways. And I looked across the specialties, and I also looked at paediatrics. And what I found is that most of the information that we know is about early grade doctors and why we choose to do a specialty rather than why we choose to leave. In paediatrics, there were only two sort of academic studies that related to retention specifically. One of those was unpublished, so we don't have the details, and one of those was done in 2015. It showed there's an attrition rate of about 15% between the first and third year of training in paediatrics, but most of the information there was quantitative. So I decided to do a project that was more qualitative, thinking about the why. So my questions are, why do people leave training, and is there anything that can be done to help training, to help people stay in training? And this is my project. So without going into too much detail, which I'm happy to share with you afterwards if you want more detail, I did a project which involved in-depth interviews with paediatric trainees from across the country. So I looked at 5 different training regions, recruited them via social media, and I was overwhelmed with the number of responses that I had. Everybody wanted to tell me how bad it was in paediatrics, but I had to be quite specific. So I chose 4 groups. I interviewed 14 people. It took between 40 minutes to 2 hours for each interview. review. And the groups were people who had left paediatrics for abroad, people who had left for a different specialty, people who had left medicine completely, and there were 2 participants who had remained within paediatrics but had decided to not go on with training. And I'm going to tell you a little bit about what I found, because obviously it's quite a big project. I'm going to tell you the main things. So what did I find? Well, there were so many different reasons to leave paediatrics I couldn't possibly explain, and some of them were very individual, some quite worrying ones, such as experiences of racism and dealing with chronic ill health. But what I thought I'd take you through is some general observations which I think might help us. So there were multiple push or pull factors. Push factors, the negative factors, were much more frequent than pull factors, and that's a difference from the 2015 study. So it thinks that we might be thinking about paediatrics in more of a negative way. And many people wanted to work fewer out-of-hours shifts, but there were so many different drivers for that, so it's important to think of the individual and not just treat everybody the same. I think what's the most important is that everybody bar one made the decision based on cumulative effects, so a result of lots of different things added up. And I think the reason that's important is because if we want to try and reverse that trend of people leaving, we need to think about making small changes. It's not going to be one thing that makes a difference. And also, importantly, is people were giving equal weight to all their decisions. So it wasn't just the fact that they wanted to work out of hours. That's important because we can then try to counteract the things that are more amenable to change. So it can be seen as a challenge because it's quite difficult to find an outcome measure. If we're going to change one factor, it's hardly likely that one of those factors on its own is going to change the whole of retention. But it's also an opportunity because it means that we can change lots of small things which might make the difference to the training experience in total. Another quick thing is that people had a tipping point. So this is a girl who had wanted to come back after her maternity leave. Unfortunately, she asked several months in advance if she could be put not onto night shifts for the first shift back. And of course, where did she end up? On a night shift on the first shift. And she said, I don't think I would have quit had it not been for a difficult time after maternity leave. Had there been a bit more support with me coming back, I think that was the last straw. I wasn't even asking to do less. I was asking for a swap. Another girl had had a severe crash on the way to work and ended up in intensive care, and a year later was put in the same hospital despite asking not to be there. And unfortunately, she developed flashbacks on her commute on the way to work and asked for help. The difficult thing was both of these people had decided to leave after they got the help, and the important point here is not that they wouldn't have left because there were other reasons for them having left paediatrics, but it's the timing of support which is important and the recognition of when people are having problems. So most people were happy with the decision to leave, but some didn't want to leave, with one person saying, I didn't leave because I didn't like the job, I left because I couldn't make it work. And the reason that's important is, again, it shouldn't be seen as a negative to leave, but it's important to assess factors which might improve retention. So I thought, well, what can we offer people? What might make people stay? Could we offer people less than full-time training? Well, the answer is no. Nobody wanted to prolong the agony. But there was one person who thought that if she did come back part-time, she would have done so on mental health grounds because working full-time was affecting her mental health. Did anybody want any more money? Well, surprisingly, nobody wanted any more money. And it was quite a clear sense from the group, although it was a bit more nuanced where there were parents or where there was parts of the country where the cost of living was higher. But interestingly, while no one was motivated by money, they were all demotivated by the perceived devaluing of them because of the problems with the junior doctor contract. 2 participants had gone from a training post to a non-training post, and one of them said the reason why she didn't want to quit her number initially was that she felt that most staff grades were there to prop up the reg rota, that they worked on the reg rotas and are dumped on and they don't get to go any of the training. And so I think what's interesting here is none of the participants were aware that you could become a consultant through the non-training route, but all of them felt that this would be something that should be promoted more by hospitals and by the Royal College of Paediatrics. So moving on, I'm briefly just going to talk about some themes which I found, because basically everybody had similar experiences in paediatrics and had factors which overlapped. And I developed this model which is based on the 3 main themes here, so psychological well-being, which is low morale, stress, and mental health concerns, control or lack of control, and support. And my idea is that if we can increase control and support, that it may be that we can counteract some of these negative aspects of psychological well-being in the stress that people are feeling. So I'm just briefly going to talk through some of the themes here, bearing in mind that all of these changes need to be considered with local, regional and national policies in mind. So stress, everybody was stressed. Well, it's hardly surprising. It's quite a stressful job, and most people had concerns about being a doctor in general, but what was more apparent, rather than the exam stress and changing from junior to senior roles, was that there was more stress across the board, both in juniors and consultants, and increasing with time, and people were becoming quite concerned about their own mental health and how they would cope. Interestingly, most people thought there was increasing stress because of the expectations of society and expectations of government and the GMC. This was somebody that had to change because she had 2 friends who committed suicide, several mistakes at work, and she just reached the end and couldn't do it anymore. Everybody felt that the morale was very low, and that they were being treated as if they were service providers only, and that's by the government and by hospitals themselves. So the implication is not that the existence of stress is surprising, but these were not outlying experiences. There were similarities across the group and across previous research from the research that I'd done. And what was really apparent was that people were fearful of making mistakes, and they were concerned about their effects on their own mental health. And obviously that ties in with the Dr. Bawagara case that I'm sure plenty of us are aware of. So moving quickly on to control. So I defined control as flexibility, choice, continuity and predictability. Flexibility in the training structure and training requirements, choice of placements or rota slots, predictability of working arrangements and continuity of training and supervision. And surprisingly, people felt that there wasn't that much control over training. And I'm just going to go through a few examples of what that might be. So this was a person who was upset because she'd been made to work on the surgical rota gap long-term along with all her other SHO colleagues. And because there's so many gaps in the surgical rota, it wasn't the fact that she had to do it, but the way it was done. There was no conversation. It was just, you have to do this. This is somebody who said, my friend was getting married. She had emailed 9 months ahead and said, please don't put me on call for then. And they said, sorry, we don't take personal requests into account. So she's going to find out 8 weeks before if she could go to her wedding or not. Control of placements is very different nationally about how people are assigned different placements. So we rotate around lots of different specialties, but that's done in a very transparent way in some areas and not so much in others. This was a person who said, I think in the early times, I didn't realise that I could have spoken to the programme director and requested. I didn't even know that was a thing. So she felt that there was a lack of control over your choice for a career in the future, because it would just be, if you happen to know the programme director, then you might get a chance at doing the placement that you wanted. And then training structure. Everybody felt that training structure itself, while run-through training was good, so we do years 1 to 8 run-through training in paediatrics, there was lots of restriction because of the fact that it was difficult to split it up, it was difficult to go and work abroad, it was difficult for previous work abroad to be recognised, it was difficult for you to have timing of career decisions, so if you wanted to do a subspecialty, it's a very fixed time within paediatrics when that's possible. So lots of things which actually the Royal College of Paediatrics is working on in their shape of training review, but I'm not that sure, to be honest, how much of that will be beneficial for what trainees actually want. And then finally, control over the portfolio. People felt that it was a tick box exercise and meant that it didn't give them much chance to look at anything else in their training. So what's important about all this? I think that it's areas that were perceived as amenable to change but were not facilitated is the important point. So there's an acceptance that we all need to go around different hospitals, but there's a lack of transparency in assigning placements. There's an acceptance of needing to provide evidence, but people are unable to focus on other aspects of their career, and an acceptance of the need to work out of hours, but people weren't able to choose rota slots. So finally, I know I'm probably running out of time, thinking about support, everybody thought that paediatrics in general was a very supportive specialty, but that more and more consultants were having less and less time to be there for their trainees. Educational supervision, so lots of people felt that educational supervision in parts of the country where it's a run through from the first to the final years of training was useful, because it meant that educational supervisors got to know their trainees and could look at them holistically and think about their career planning and psychological development. That doesn't happen everywhere, and it was clear that trainees wanted more from their educational supervisors. Poor educational supervisors have got so much other pressures on themselves. And then psychological support. So interestingly, those trainees who had problems with depression or other mental health concerns were all looked after very well by their colleagues. But where there was a problem was those trainees who had concerns about their own mental health in relation to the work that they were doing, because they didn't know who to talk to or if they should talk to anyone. And LinkedIn was that. linked in with that was support for incidents, and across the board people felt that that wasn't very well done. This was a trainee who had suffered because there was a series of neonatal deaths which she was involved with, and she had to go to panel to explain herself is how she saw it. She said, "I doubted myself, I saw it as my own fault, and I know that I didn't speak up, but it was because there was this fear I was being incompetent. I was fearful. There was a joke made at handover, oh, the Grim Reaper. They thought I was confident in myself," and she explains that she had subsequently went and cried in the toilet. So this is really sad because she felt that she lost confidence in asking for assessments and lost confidence in the whole of her training because of these incidents. And finally, support for return to work and information about training requirements from the college and from hospitals was thought to be inadequate. The wider context there isn't time to talk about, but everybody hated the government. And also the GMC. So what does this all mean for us? I think we need to consider making cumulative improvements, and I think it's very easy to despair and say it's all a disaster, but I think there are things that people can do to change. We need to think about reducing the negative push factors and trying to emulate other specialties. So, for example, I found that people were more interested in doing research and in leadership roles, which they didn't feel was possible within paediatrics, but was more possible in other specialties. We need to consider how widely felt are these experiences. Obviously, my study was a qualitative study, but I think if you asked everybody in the room probably would have some similar experiences. We need to think that whilst the previous literature shows that people who choose paediatrics are less concerned with so-called lifestyle factors, my study has shown that that's not always the case later on, particularly because people's lives change. Paediatrics is a long training time and people's life circumstances often change within that time. I think blaming generational differences is not enough. The trainees themselves had lots of ideas. I think one of them is we need to think about what do people like about working at specific hospitals, because we all know that everywhere is really busy, but if you ask trainees, they're in a very unique position in being able to rotate around different hospitals. They actually like different hospitals more than others, and I think we need to work out why. And anecdotally, that's not because they're all busy, because they're all busy, but some are better than others. The trainees had ideas for appreciation schemes, so rather than the day ticks, there was the grey ticks, and although giving someone a certificate for doing a good job is not going to make them keep the job, it will improve overall morale. So I think a lot of this is about creating value. So people are not motivated by monetary, it's non-monetary factors that will motivate them. And I think it's how do we create that value in the team and make people feel that they're enabled to be involved in change. I think if you involve trainees themselves and involve them in communication, that's a really key factor. Lots of them felt that we should have training in debriefing. There was advice about career forums, like somebody had been to a career dating, kind of a speed dating thing for careers. And then promotion of non-training grade positions. How do we think about continuity of educational supervision and protected time for training? And importantly, psychological support and ending this culture of silence, which I think is probably way behind the rest of society. Everybody else is opening up about their mental health, but in medicine, it's still seen as a weakness. I've brought along a copy of a blog. I've only got one copy of it, but it's by the head of the Royal College of Obstetrics and Gynecology in Australia, who's talking about his own experience of having nearly committed suicide when he was a junior doctor. And if anyone hasn't read it, I'd strongly advise you to do that. And the reply which comes, it really is makes you quite sad, but also it's quite positive for the future, I think, about how we talk about these psychological concerns. So that's it, really. In conclusion, paediatrics is not inherently unenjoyable, but we do need to think about factors which attract people to the specialty are not the same as those factors which will make people leave. We need to listen to trainees, but we also need to listen to consultants because they're also under significant pressure, and I'm sure we'll be having some similar experiences. And I think if we can improve control and support, we may reduce stress. I think, importantly, we should learn from regional differences, which you can see are a few in my study. And not all improvements require money, but we do need to think that systemic pressures cannot be ignored. And finally, I'll just leave you with this quote. This is from one of the doctors, and she said, "And then I had to take a step back and think, I'm a person over a doctor." Thank you very much. So I'd just like to thank my supervisor, Dr. Huda, who's a good example of an excellent example of an educational supervisor to help me today with this, and my supervisor in Edinburgh, which is where I did my degree. If you've got any questions, feel free to email me.
Thank you very much, Emily. I mean, that's actually quite amazing to listen to that, and I think it resounds, isn't it? You look at it like, I felt like that at times as well, and it's a bit scary, really. Any questions for Emily? Alison, do you want to be on the spot as well?
Thank you, Emily. That was really good, and unfortunately a lot of it did ring true for our training. I just wondered if anything in your study came out to say, so I know that the Royal College was looking at shortening our training length, but at the same time I meet an awful lot of trainees who are very reluctant to go in consultant posts because they don't feel ready. How do we balance the two things? Because people don't want to be in training, but they also don't want to be in consultant posts.
Yeah, exactly. I think that, yeah, there were quite a few concerns with trainees about the balance of clinical support they get in their training, because a lot of people felt there was too much, a lack of autonomy. People felt unprepared for their clinical post as a consultant, and felt that there would be in paediatrics a scenario a little bit like you get in surgery, where you get people that don't have the same skills in their training than they probably would have had in training, say, 20 years ago. But I think it's about flexibility. I think the training structure itself needs to be flexible based on what people feel are their strengths. So, for example, there's some people in paediatrics who feel that they want to do general paediatrics from the start, and many of the people that wanted to do that felt that they could have done less of some of the specialties, and they felt that they could probably have trained for longer in one kind of hospital, for example. Whereas there were others who didn't quite know what they wanted to do in terms of subspecialties, felt that the training structure really didn't allow for them to change their mind later on if they'd experienced something which they later enjoyed. So I think the structure has to really be about flexibility, about it not being the same for everybody. While run-through training, it's got its advantages, I think we need to also think about ways of splitting it up and making the possibilities for different options within that training programme.
When you came, I've got a couple of points. One is a question. When you came to looking at the rotas and frustration with that, was it also that people felt that it wasn't going to get any better and they could see consultants doing equally as bad hours? So was it a sort of a combination, or was it the rota they were in at the time?
I mean, to be quite honest, although my project was on rota gaps were kind of in the background, just making everything worse. I think there was an acknowledgement that a lot of these stresses had existed for quite some time, but the rota gaps were just exacerbating everything. But there was a huge, there were quite a few people who specifically left because they could see the pathway it was going down for consultants, and they could see that consultants having to provide resident on-call shifts was a big issue for them, where perhaps that hadn't been the case when they first started paediatrics, say 10 years ago, if they'd been working less than full time, for example. So people did see this inevitability that the job of a consultant is hard. And I don't know how we try and change that, because I think that is the case, isn't it?
And the other thing was, it's great that you've presented it here. Where else have you taken it? Because, I mean, there's some actual quick wins, isn't there? In the Northwest, we don't do that educational supervision all the way through. Yeah. And I could see how that would help. I mean, I struggle in a unit where we've got a lot of consultants and a lot of juniors to even keep, close contact with the one I have for 6 months or 12 months. So I think that would work if that's what people want. Obviously, you'd have to do some travelling because all regions are big, but has it gone to all the programme directors and the deaneries just for information about things they could do quick wins on? I mean, that's the thing. Some of these changes are local, some of these are national, some of these are at deanery level. I think the educational supervision thing, again, is a flexibility issue. So some people will want different things. Some people might, not particularly get on with one educational supervisor. So I think there has to be choice there. But in terms of sharing my findings, I've shared my findings with the head of the Royal College workforce planner, who was very encouraged by the project, but felt that I need to publish it. So I'm just going to try and get it published. In terms of sharing it with other people, I have let the trainees committee know at the Royal College that I've done this project, but I haven't actually got any plans to present it anywhere else. So if anyone wants me to present anything else, let me know.
Hi Emily, I'm Julie Sutcliffe, clinical lead paediatric physio over at the Royal Preston Hospital. And I know you've spoken from a very medical perspective, but it's not just medics.
No.
And I think a lot of the things that you've said resounded very much with us. We've seen a hemorrhage of very senior staff. And I think one of the questions that should be asked at exit interview is there anything I could do to make you stay? Because we invest so much time and energy in our staff. And I think it may well be because the managers are as demoralised as anybody else. They just think, oh, it's another one, bites the dust, off you go. have a nice life. But
Yeah.
actually we are losing a lot, and I think AHPs, like medics, are not motivated by money, so, and they're often just very small wins and small changes that could be made to keep those people in post. And I think what we need to learn to do, probably from the bottom up, because I don't think the government are ever going to value us, from the bottom up is to value each other and be very kind to each other. I work in a very small paediatric team, and on grassroots level, that's what we do. We have supervision, we speak to each other, we care about each other, and we know each other well enough to know whether that person walks into the office, it's a bad day, what's the matter, what can I do? And it might be mental health things, it might be personal things, it could be anything, but one of the first questions is everything okay? Is there anything I can do? And I think we need to start being a little kinder to each other.
Yeah, I think that's absolutely right. I think it's very true, certainly for the people that I spoke to. There were several examples. Well, hardly any of them, for example, even had an interview to say that they were leaving. One person sent in an email to say, I'm leaving, and didn't actually hear back. She'd moved to Australia by the time they actually said, oh, do you know that you're working at this hospital next week? And she felt that that in itself just proved how much they were devalued. And I think you're right, it's talking about how we actually create that sense of value within the team. And I think we all have to. It is very challenging times, but I think it is trying to find ways that we appreciate each other, even if we know that these outside changes are going to be there for the long term.
Thank you, Emily, for a really fantastic presentation. It's left me quite upset listening to some of those stories, and some things haven't changed over the years in terms of training. I suppose I'm looking at people in the room. We've got a responsibility to address some of the things that you've talked about, and some of the things that are within our gift to change within Lancashire, so we can address some of those things in Lancashire. So that's one thing. I guess we need to take away your recommendations and take it to the ICS or wherever to improve those things and that training experience. But also, you mentioned the national context, and I think we need to keep lobbying upwards as well. We need stronger voices to say to government, actually, we're not happy with this, to the GMC, that we're not happy with certain things. I think that voice needs to come from the ground. I think we need to keep talking about austerity and the impact of austerity on our population, on demand, on our services. My budget gets cut every year, and it has an impact on the services that can be delivered at the front line. I think those things we have to talk about those things, and we have to hold our government to account.
Absolutely, I agree with that. And I think it's very easy for doctors sometimes just to forget that we're, actually part of a whole economic and social system because we've got the patient in front of us. So I do think it's very easy to become demoralised by that. So I think you're right.
I think we'll move on to the next talk. One more question.
Okay.
Hi, sorry. Just to say, I work for Health Education England, and I'm the workforce planning lead supporting our ICS. So I've written down your email address, and if that's okay with you, I'll make sure that it is shared with our postgraduate dean and colleagues who'd be really interested in your research.
Great, thank you very much. Thanks.
Thank you very much, Emily. I think this really cuts straight to the heart, and I'm sure in the break we can talk about it more, and Emily will be around, so we'll be able to ask her more questions.